Welcome to Neurosurgery Tales. The first question, of course, is what inspired you to become a military neurosurgeon?
Yes, so my choice as military neurosurgery was out of two things. One was at that point I had a large military commitment because my undergrad was at the United States Military Academy at West Point. So I owed time for service for my undergrad. And then I also timed for service for my medical school, for a military medical school. So I went to the Uniformed Services Military Medical School. So both of those combined was a total of 14 years to pay back. And I was inspired to go into neurosurgery by several graduates of West Point who became neurosurgeons, to include Jim Eklund and John Brophy and Steve Andra, all current contemporary neurosurgeons, and William Minacci. So they were a couple of years ahead of me at West Point, and they inspired me to go into neurosurgery. And then there's a very famous West Point neurosurgeon who I was very inspired by his writings. It was Thorolf Sunt, who had been the chairman at the Mayo Clinic for many years. But when he came out of West Point, he was actually an infantryman and served in Korea at the Battle of Pork Chop Hill before he went into medicine. So he had quite a legacy and story that was very inspiring to become a neurosurgeon. So I got very interested in neurosurgery because of these other mentors and role models that I had. And I just sort of fell in love with neuroanatomy as a medical student. It was only 3 credit hours for us, but I think I spent probably the majority of my time studying neuroanatomy, even though it was probably less credit hours than parasitology that we were taking at the same time. But I just found it just fascinating. So I sort of fell in love with it.
Wow, that's amazing. And before preparing for your mission to Ukraine and Iraq, how do you prepare for those missions? Were different preparation for each of them?
It was very different, yes. You know, when I deployed active duty in the Army, we had a clear mission that we were basically shadowing different combat teams. So at the time, we were shadowing the 18th Airborne Corps, and in this case, it was going to be, it was initially the 82nd Airborne 101st, but then it turned out to be the 3rd Infantry Division and the 1st Marine Division that we became attached to. So where they went, we went. So when they went into Iraq, we went into Iraq. We weren't quite ready to set up in Baghdad once they tipped Baghdad early on. So we were out in the open desert for about 6-7 months until we moved into the city. And in that environment, you really understood what austere meant. You know, you're doing surgery in tents. The CT scanner wasn't working very often. We did use a C-arm to do some angiography, but it was very rudimentary. And then later we moved into the city, into what's called Ibn Sina Hospital, which was a fixed hospital in an area known as the Green Zone in Baghdad. And we had a fixed CT scanner and some other equipment. The mission to Ukraine was very different. I got involved in missions to Ukraine through several different colleagues. Initially, it was military colleagues who I knew who were retired, who were helping from the trauma standpoint, helping Ukrainian surgeons basically do trauma care. And then they said they needed help with neurosurgical equipment. So I got involved in logistics equipment issues. And then I linked up with a neurosurgeon in New Jersey, Luke Tomczyk. And Luke had been doing missions to Ukraine, ever since I think 2018, 2019, through an NGO called Razum. And Luke was helping me deliver much larger pallets directly to Professor Serko in the city of Dnipro. And so I looked at the city of Dnipro, I looked at what Professor Serko and his colleague Yuri Chernychenko were doing in Dnipro, and they were really the point of the spear. They were one of the busiest hospitals in all of Ukraine in terms of skull-based tumors, vascular, and all the combat casualty care. So they're really sort of the biggest medical center closest to the front in the eastern part of the country. So then I collaborated with one of my former neurosurgery technologists who's Ukrainian, who was one of our OR techs, Ivan Bezkorovany, which means without bread in Ukrainian, Bezkorovany. We had a lot to talk about. So Ivan basically helped me coordinate this trip from landing in Krakow, bringing our medical equipment via car across the Polish-Ukrainian border, and then taking a 14-hour train from Lviv to Dnipro. So this was under the auspices of the ROSM NGO missions. But really, it was Ivan who did most of all the logistics for me the first time around. And then the most recent trip that I did this past February, I had a little bit better understanding of the lay of the land, and basically was able to coordinate this as a solo mission just with ROSM in terms of the train. I was already in Warsaw doing a course for Department of Defense, collaborating with Polish military and NATO. And I took a train basically from Warsaw to Kyiv, and then from Kyiv to Dnipro, and then back from Dnipro back to Warsaw.
So that's a long trip.
It's a very long trip. Yes, it's about 36 hours in a train. You have to realize you're not going to have wireless, and you basically just have to be very patient. Most of these are sleeper trains, so you're going to have like a little place to sleep, and you have area. I bought 2 tickets, so I have 1 ticket basically just for all the medical equipment I was bringing. But some of these cars actually sleep 3 people. So every now and then you might have a guest that joins you unexpectedly. So you have to be adaptable, and you have to be willing to sort of hold conversations, even though you don't speak Polish or Ukrainian, and hopefully they speak English. Yeah.
What was your first thought when you have been deployed to Iraq, when you arrived in Iraq?
Oh my goodness, my first thought was, what the hell are we doing here? I mean, my first question was like, what are we really doing here? Because we literally were in the middle of this open desert and setting up this combat support hospital. And it just didn't make any sense to me because we were so far away from where the airport was in the city. It logistically was just sort of a nightmare. Because to get casualties, they had to come by, Humvee ambulance or by helicopter. And then to leave, they had to leave by either Humvee ambulance or by helicopter. So you're not at an airstrip. It didn't make a lot of sense. Usually you try to put your biggest medical resources at a large airstrip so it could be resupplied, and then you can move casualties out, in a quicker way. But that's not. They didn't really ask me. They didn't really seek my opinion on that one. It was sort of like you went where you were told, and you try to make the best of it. So we try to make the very best of our circumstances and try to, improve patient care for where we were at, which was a challenge at the time.
Yeah. Can you describe for us a typical day in the field?
So, in Iraq, it was very different because you go through these periods where it was very, very slow. And then all of a sudden you got multiple casualties all at once.
Yeah.
In Ukraine, it was much more continuous. Ukraine, you're basically in a fixed facility, a large medical center. In this case, it was Mechnikov Regional Hospital, which is a very large hospital. Its standard is 1,200 beds. And they were taking up to 1,670 patients when I was there in February. So it's very crowded with patients, but it's a standard fixed facility. Whereas in the desert, you're landing patients basically in an open sand area, and then you're moving them through these tents, and then in through these tents to an operating room that's basically like a double wide trailer. So you're very constrained by resources, by space, by complexity. So you don't really have an operating microscope. Most of the time we didn't have a functioning CT scanner. Like I said, we did have fluoroscopy, but that's about it. So it's a very different level of surgery that you're going to be able to do out there. Versus in Mechnikov, you have, digital subtraction angiography. You have CT scanners and CTA, standard. You even have MRI scanners, but we weren't using much MRI there. So it's a totally different level of care. You have, very high functioning operating rooms with state-of-the-art Leica and Pentero, Canevo, Zeiss microscopes. So they're used to doing complex neurosurgery, both vascular and skull base at this institution. So it's a very different kind of environment. It's almost like if you took Walter Reed in the formal fixed facility and you moved it into Baghdad or you moved it into, Bagram Air Base in Afghanistan, because you're that close to the casualties. In Ukraine, we were anywhere from 2.5 hours from Avdiivka, and Bakhmut, and maybe an hour from the southern casualties near Zaporizhia. So you can get patients pretty quickly.
And the type of injuries in Ukraine and Iraq were different or the same?
There's a lot of similarities. The difference was that one is the volume is much higher, almost 10 times higher in Ukraine, a much higher volume number. The other is that it's not like improvised explosives. These are high energy artillery rounds. These are what they call mine blast trauma, so mortar rounds, drone attacks, direct fire weapons, gunshot wounds. So it has a much more lethal effect, in other words, because if you look at artillery shells exploding as an air burst, it's much more lethal than an explosion that's buried in the ground as an improvised explosion. So it's very very different type of what you would say lethal dose 50 LD50 to the range of those weapons. The polytrauma you would see. So you see limbs, thoracic, abdominal, a lot of penetrating neck injuries from fragments as well for neurovascular injuries to the carotid vertebral artery, and then maxillofacial and cranial injuries as well. So a lot of these blasts are coming from above, and as they come from above, it causes somewhat of a different distribution of penetrating trauma to the cranial vault and neck. And opposed to something that comes up from the ground, it's a different trajectory. So that's somewhat different. But the biggest thing is just the volume. The volume is literally 10 times the number. At this one hospital, when I was there in May of 2023, they were up to about 14,000 combat casualties. When I went back there in February, they were approaching 26,000. And then in March, they hit over 27,000 combat casualties. So that's quite a bit. That's on order of what we had over a 20-year period in Iraq and Afghanistan in 2 years. So it's quite a bit more. Yeah. For example, if you look just at like the amputees, we had an order of about 2,000 amputees in Iraq and Afghanistan. And in Ukraine, they have, no one knows the exact number, but it's somewhere ranging between 35,000 to maybe 50,000 amputees. So it's an order of magnitude greater. That's right.
And those patients that are coming in with multiple trauma, for example, for the brain and the abdomen, or
that's right.
How do you treat them?
Yeah, so that's a great point. So in front of us, right at the battle line, maybe 5 to 10 miles, or about 10 kilometers from the battle line, there is a damage control mobile surgical hospital made up of trauma surgeons, and then a little bit further back, there's a neurosurgery level. So many of these patients have already had their damage control general surgical procedure. So they've had their amputations, they've had their exploratory laparotomies, their airway has been secured, their blood pressure has been stabilized. If they had like a large mass lesion, like an epidural hematoma or subdural hematoma, those were already evacuated. So the patients that we would see typically had penetrating trauma, maybe associated with an intracranial hemorrhage, maybe associated with a neurovascular injury, maybe associated with pneumocephalus. It could be open penetrating trauma as well, but it wasn't like a massive epidural hematoma and a blown pupil. Those patients had already been intervened on. And most of the work that we were doing was basically complex skull base type trauma and trauma to the cranial vault with penetrating fragments that
Mm-hmm.
would go into the ventricular system or into the through the frontal sinuses and into the interhemispheric fissure, for example,
Mm-hmm.
or fragments that went along the skull base and caused significant CSF disruption with massive pneumocephalus and things like that.
And for those who have penetrating injuries with fragments that were not in eloquent zones,
Yeah.
would you leave them there, or
Yeah, that's a great
you'll
question. So we didn't go chasing after fragments. Our
Mm-hmm.
purpose was basically try to take out as much of the fragments as we could within an
Mm-hmm.
accessible area, but not to create more collateral damage taking fragments out. Many of the fragments were actually not necessarily metal, but could be secondary bone spicules that basically were driven into the cortex. And much
Mm-hmm.
of that was irrigated out, or we actually would take them out with... and Dr. Circo was very good at this using the operating microscope. He would bring the operating microscope in once he opened the dura, and then use that to basically debride and repair that area of the skull base, for example, if it was a penetration into the orbit or penetration
Mm-hmm.
into the middle cranial fossa or into the sphenoid sinus, for example. But we wouldn't necessarily go after deep fragments that were metallic, that were very small, that were otherwise fixed. Now, in some of these cases, we had large metallic fragments that would move around. And there have been occasions where we went after fragments that would migrate. And so you'd have to get follow-up CT scans. Sometimes you see these fragments get into the ventricular system and they would move, or they'd be in the skull base and they would migrate from the area around the anterior cranial fossa in towards the posterior cranial fossa, or anterior cranial fossa back towards middle cranial fossa, or all the way back towards the occipital lobe even. So those fragments we did remove.
I see. For the patient's outcome in the battlefield compared to those in civilian settings, it's different. And what factors do you think contribute to these differences?
Yeah, there's a lot of differences. I think, when you look at civilian penetrating trauma, and unfortunately in Washington, D.C., we have way too much, a lot of that is almost point-blank gunshot wounds, where the gunshot wound victim is within a very narrow distance of the penetrating trauma, and like a carjacking, for example. And unfortunately, many of those, even with our best resources immediately applied, they're not as survivable, believe it or not. In terms of penetrating trauma from war, you can say there's, let's say, three different groups. There's those groups who, let's say, it's so severe, they're going to come into that first echelon of care without any responses. GCS3, no mass lesion. In those patients, you may not be able to do anything. But then there's another group of patients who have a mass lesion that would benefit from an evacuation, like a subdural hematoma, epidural hematoma, as a secondary effect from the blast injury or from penetrating trauma. And then there's another category of patient, the third category, which don't necessarily have the acute large mass lesion, but they have penetrating fragments that cause significant injuries to neurovascular system or to parenchyma and or CSF leak. And they also would benefit from surgery. So part of it is that there's a overall, with trauma surgeons and your first echelon folks, they see a penetrating brain injury patient and they say, well, it's not going to be survivable. But in many of these cases, it is survivable. So you have to sort of overcome some of that nihilism and show that these patients can actually survive and regain function. And I think the Ukrainians have done a very good job at that because they're very dedicated to saving lives. And the combat medics and the frontline trauma surgeons are very active in trying to prevent secondary injury. They're very good. But what a lot of people don't realize is that they don't rotate. Many of those surgeons have been there literally for 2 years straight and operating nonstop. So it's a very exhausting process. It's almost like you have two different countries at war. You have the eastern side of the country, which is nonstop engaged with casualty care. And then the western side of the country, which is not really seeing the acute casualties as much. And they're involved in their regular elective civilian practice. And so it's hard to join the two together. I think, encouraging the folks from the West to rotate to the East to volunteer would be one way. I think some form of mandatory service where people are rotating in and out and they're getting the experience and then giving a break to those frontline surgeons would actually be very beneficial. But I worry about the surgeons burning out because many of the large surgical teams have actually lost a lot of folks because when the war started, their house officers were from other countries and they lost their visas. So their house officers decreased. And then they lost some of their senior attendings because they had, again, younger children or not really been adapted to being able to stay and take care of combat casualties. So they lost both the very young and the very old surgical groups. And the people who remain basically are carrying the burden for the entire country. So it's one of the things I noticed. And the attendings, for the most part, in Dr. Serco's team are very young. They're between 28 and 32. So, that would be like the age of some of our mid-level to senior residents here, right? So it's quite remarkable to see them operating independently day in and day out. They're doing an incredible job. But I do worry about their, getting burnt out.
That's, of course, an issue. I can imagine working straight for 2 years and with all those bombs and missiles and everything. It's
it's very shocking because they're not necessarily being bombed in Dnipro every day, but there's air raid sirens going off multiple times during the week. There's different random buildings that are being hit. And it may not necessarily be your house or your hospital, but it's in your neighborhood. For Professor Serco, it was almost less than 300 yards from his home. And it was a big factory that was hit twice. So it's quite a bit of additional psychological trauma about your own survival and your family's survival, in addition to doing your job, going to work every day. So it's really hard to explain that to people back in the States, because in the States, we complain about silly things, traffic, getting our coffee, parking, things like that, right? Here, they're like, their neighborhood is blown up. Here, it's like, how am I going to, guarantee the safety of my family and safety of my team? But it's very important because like Professor Serco, he's the leader for his unit for the cerebral neurosurgery and neuro-oncology and neurotrauma. And people look up to him, the nurses, the residents, the other attendings. And so you have to set the example by being present. You have to show up. And that's really challenging when you're worried about your own family. He has 2 sons. One son's about 12 and is at home most of the time with his wife. And his older son is, I think, 25 now, just turned 25 or 26, actually. And he's a neurosurgery resident. So he's actually been working side by side with his father for several years. And his son, Bodan, has actually volunteered and served in some of those mobile hospitals right off the front lines as well. So that's where I got a lot of my information, was from Bodan's experience and him sharing it with me about what he saw at these frontline hospitals. And it was quite dramatic. So it's also an amazing training opportunity for young people, from people in the States and from people in other areas of Europe to join and to basically become a better surgeon, a better physician.
Can anyone just call and join, any neurosurgeon, or how does it work?
Yeah, you're vetted through ROSM is the way it works in my particular situation. They look at your background, they look at your reputation, they try to find out, where you've practiced, so forth. And, Luke Tomczyk is the senior person who basically evaluates neurosurgeons. And they also do this for plastic surgeons, for oral maxillofacial and ENT. And they've had other surgical services that have rotated over there. So they have a whole process of, vetting people. They want to make sure that people are going for the right reasons,
Yeah.
that people have the right skill sets, and it's a cultural exchange. It's not like you show up and you just do all these operations. You're basically assisting, advising, and advocating. So you're not going to go in there and just knock out all these cases. That's not the way it works, right? The way it works is you show up and you find out how you can be helpful and
Yeah.
not obstructive, right? That's the first thing. And you're very respectful for, what's the established hierarchy, because they've been doing this for centuries. I mean, this one hospital had been around since the 1797, since, before the Crimea War. So it's like, they have a long tradition of medicine at this particular hospital. So you have to sort of see how they do what they do with what they have, for example. And then you have to say, okay, how can I help? What is it that I can help? Maybe it's with logistics, maybe it's with assisting in operation, maybe it's with advocacy. So that's how you make a contribution. And I think from a younger resident standpoint, we had a resident from UVA who went, and he went for 3 weeks, Connor Berlin, and he did an amazing job. And he saw things he had never seen before. Like, he had never used a Hudson brace before. He had never used a Gigley saw before. And it was these young attendings who were his age or even younger who were teaching him how to operate with these other instruments. And I think you learn a couple things. One, you learn a versatility to use different instruments. Number two, you learn how to make things happen with what you're given. And number three, you learn factors of resilience and strength and character about what it means to be able to perform in a wartime environment with multiple stressors. And the stressors are, again, the patient volume, the young age of the patients, the complexity of their injuries, and managing that with your own energy and stamina.
When you're there is some things that nobody can understand unless you have been there.
Yeah.
And what are those challenges? Especially
that's
when
a great question. Yeah. So, my family said, why are you going, Dad? Why are you going again, Dad? Why can't you just do webinar with them? We don't want you to go back into a war zone. You've already done your time in a war zone. And I think that there's certain things that you don't really understand until you're physically there. And part of it is what the injury patterns are and what the exact parameters are of equipment that they have to use, what the complexity of management is in this environment. Because there's such a turnover in patients. You have to basically move patients in and out of your facility every couple days because you have to be able to take in more patients, right? So once a patient's stable after you've operated on them, craniotomy, it might be 3 days, 4 days. You need to get that patient out, be a hospital trained, make sure that they're stable so you can get more patients in. So you don't keep patients in the ICU for a prolonged time for multimodal monitoring, for example. It's just not practical because you have to make more beds available for the next onslaught of casualties coming in. So you can't just do a wait and see for a lot of patients. You need to either operate now or the patient doesn't get surgery. So it's like one of those situations where you're not sitting on patients to wait for them to develop secondary complications, for example. You're much more proactive in terms of your surgical intervention. And that's just the nature of the environment, right?
Yeah.
You don't have the luxury of basically seeing the same patient over a 7 to 14 day period. That patient needs to be moved out. So given those circumstances, you have to basically be able to do much more definitive surgery up front early and then get that patient moved out to a more stable setting. So
based on your experience, what policy changes would you recommend to improve medical care in those zones, in conflict zones?
Yeah, I think the couple things that were just obvious to me that I've talked to some of the neurosurgeons about, and Dr. Circo in particular, is improve the rotations of surgeons and hospital staff from the west to the east. So you make it basically a programmatic, outlined, that people rotate through. So they share the workload. They also share the experience, and they relieve those who have been exposed to this enormous volume of work, both psychological, physical, spiritual, over the past 2 years. So improving rotations and coordination through the medical system. The other is, Meshnikov works very well as a civilian hospital, taking care of both military and civilian patients. They're in this eastern city of Dnipro. But the problem is that far on the western side of the country, in Lviv, or even in the north, in Kyiv, there isn't that same collaboration. You don't see the civilian military hospitals working hand in hand. They're almost separate sort of institutions where they don't work together. The staff from the civilian hospital is not allowed to work at the military hospital. The staff from the military hospital is not allowed to work at the civilian hospital. And so
why is that?
Yeah, that's a great question. It's because they have different hierarchies, and there isn't the same exchange that you see on the East, because the needs are different. It's different needs. It's more reconstructive, rehabilitative, delayed complications. There's still serious surgeries that need to be done, but unfortunately, there's a resistance to this change, to both civilian and military working together, and they keep patients separate. So in the West, some of the best resources were actually in the civilian hospitals, whereas the military hospitals sort of did not have nearly the same quality of equipment. So it would have been better in the city of Lviv if there was more exchange going on there between the Western military hospital and the Lviv multi-trauma center, the trauma center, which had a lot of resources. So, and the same thing in Kyiv. In Kyiv, there's over 200 neurosurgeons at one hospital, but they would probably benefit if they spent some time, rotating through the front lines and rotating through the hospitals in Zaporizhia and Dnipro and Kharkiv, where there's a lot more casualties. That in a way it's tough. It's human nature, right? Who wants to leave the comfort and safety of their home and be exposed to, the risk of incoming shells, the risk of, bodily harm, of course, the risk of burnout, and then whatever is going on at home with your own private practice and your own setup back home would be at risk, right? So it's not easy just to step out. There have been a couple surgeons who I had a chance to talk to who left their practice in Kyiv, Dr. Igor Kurlitz, and literally for 6 months straight, he lived in the hospital in Dnipro, in Mechnikov. And he lived there for 6 months and did just all penetrating spine trauma. And it was amazing. He didn't have to, but he volunteered to do that. He had been served previously as a military physician in Ukraine. He had served his commitment. But then as a civilian, he came back in and volunteered to basically do this when the war first happened. So, but those are very few individuals who do that. And I think it would be much better from a system-wide standpoint that existed. So that's probably the biggest area for improvement.
And what role do you believe military neurosurgeons can play in advancing the understanding of brain injuries?
Yeah, so, someone like Professor Serko is rewriting the book about advanced management for penetrating brain trauma. And I think, what you see here is he's taking modern imaging, modern techniques from skull-based surgery, microsurgery, and pericranial flaps and skull-based reconstruction. And he's merging that with modern neurovascular, endovascular surgical techniques into the management of patients with penetrating trauma. So you see somebody with penetrating trauma who has a fistula or a traumatic aneurysm, has a skull-based defect, has retained fragments, and you're using the microscope, you're using endovascular coils, you're using skull-based approaches, pericranial flaps. You're using novel devices and equipment that's not even available here in the U.S. So they have some devices that are available in Europe but not yet in the U.S.
Oh, yeah.
to do skull-based repair and to treat some of these aneurysms.
And I just want to understand, it's a war, so there, of course, are multiple ethical complexities. How do you navigate them? For example, I don't know, maybe treating combatants from the opposite sides. I don't know if that it's even possible, but
yeah, they treat everybody who comes to them. So they treat civilians, women, children, elderly, patients who are not necessarily soldiers. They've treated prisoners of war as well. So with whatever resources they have, I think the Ukrainians have followed into the same model of basically treat others the way you would want to be treated. They do heroic efforts in terms of rescue of civilians when these large cruise missiles hit apartments. Unfortunately, that also puts them at risk. So recently, not too long ago, and last month, there was what we call a double tap attack, where they went in Odessa to rescue people who had been hit in this apartment complex. And then there was a second missile volley, cruise missiles, that then hit the fire and rescue people and killed, I think, the lieutenant governor and killed several emergency service workers. So it's really tragic to see that, because we saw the similar thing in Iraq and Afghanistan, where you as a combat medic or as a medical team, you would come into a scene to do resuscitation, and then you would be targeted by another attack. And that's just pure terrorist type strategies. That's basically to attack non-combatants and attack the psychology of the civilian population, to basically spread terror and panic. It has absolutely no military bearing. If anything, a military strategist would say, you're going to harden the civilian population against the enemy, and you're going to increase their willingness to fight and die fighting because of your tactics. So it's abhorrent. It's pure evil. It's horrible things to see when you see these buildings, civilian buildings, churches, schools, theaters, and you drive past them and you walk into them and you see massive amounts of destruction. I mean, it's one thing to see it on TV. It's another thing to walk through a building and just see entire swaths of a 10-story building that was someone's home that was taken out, everyone's apartment in that complex. I mean, it was really shocking to see that. And it also just highlights what you're up against from an enemy standpoint. Russia is not going to stop. Russia does not care about civilian casualties. It doesn't care about its own casualties. It basically has set its sights on whatever it takes. They will, be it in blood, treasure, or civilian casualties, it doesn't matter. And they've done this before. This is not the first time.
How do you manage the psychological impact of all of the things that you have seen, all the horror and evil?
You take a perspective that wherever there's evil, there's also good. And you try to focus your energies, your thoughts, your efforts on the good that exists in this whole environment of evil. So it's like an island of good amidst a sea of evil, okay? And so you're surrounded by this sea of evil, but then there's these remarkable people that you get to work with. The nurses, the technologists, the people at all levels, EMS, all the way to the professor, they're all doing it for the right purpose. They're all focused on patient care, not to generate money, not to become more famous, not to become more powerful, not to live in a bigger house, drive a fancier car, wear fancier suits, or go on fancy vacations. They're doing it because their country is under attack. They're doing it because they're trying to support freedom in a democracy. And that's a beautiful, amazing thing. If you obsess about all the death, all the destruction, all the loss, it doesn't help get you through your day. To get you through your day, you have to really focus in on the positive things about this is an amazing intervention that we're doing right now. This is an amazing save. This is an incredible team effort from the point of injury, getting that patient resuscitated, doing the damage control surgery to get the patient all the way back from the front lines to this major medical center in Dnipro within a short window of time. And they can't go by helicopter, can't go by air.
Yeah.
So all the different people who are working to make this happen, it's an amazing human chain of compassion that brings this human being to your doorstep. And so now it's in your hands. It's your chance to play your part in this orchestra of humanity to try to make a difference. And so you take heart from that. Because to be honest, when you come back to the United States in civilian medicine, it's really disheartening some days. I mean, you're like, administrators are saying, well, we want you to generate more RVUs, or we want you to add on more cases to your schedule, or we want you to see more clinic patients, or we're going to pay you less today, or, oh, you got a malpractice, suit going on, or you have to do this to cover your ass kind of thing, even though it's not clinically indicated. So in that environment, you're like, boy, that's sort of miserable. I feel more at home in an environment like Iraq and Ukraine sometimes, where bizarre, it's in a war zone, but you're feeling like you're doing the best medicine possible, So I've seen some of the best medicine in some of the worst places in my career. So really the worst places ever. But the humanity was just off the charts in terms of people coming together to try to save a life. And it's different because what your purpose is there. Your purpose there is to serve. Your purpose there is basically one single goal, and you help each other out. Everybody's always looking to help each other out. Try to give your partner a break, try to help somebody who's down, try to lift somebody else up. They have an amazing sense of humanity, of humor, could be dark humor, and ways of getting themselves through. And they're just an incredibly beautiful, resilient people who don't let anyone hold them down. They've been incredibly independent for centuries, and so it's not going to change. It's hardwired into their DNA. And so they're like, oh, this is our hardship today? Well, we'll make the best of this hardship. We'll figure a way to make something creative out of this. And so necessity becomes the mother of invention, and they get much more creative with things. I mean, one of the cases, we were using a micro Doppler that was used in cosmetic surgery that was 24 megahertz. It was this tiny little Doppler. And we had it wirelessly set up to Yuri's phone, so you could Doppler the radial artery, look at the phone, see the radial artery for his radial artery access. It was an amazing thing. I've never seen anything like that. In the U.S., we bring in this big hulking, ultrasound machine, right?
Yeah.
It's like on 4 wheels and stuff. Here, we're looking at a wireless, tiny little cosmetic ultrasound with beautiful color flow Doppler on an iPhone. I mean, it was amazing with a tiny little pencil probe. I'm like, this is incredible. And then when we were doing some of our flow diverters for aneurysms, we had this amazing software that came from Oxford Heartbeat, this group of engineers from Britain that were sharing the technology with the Ukrainians. And you could simulate exactly the length and diameter of your flow diverter on your workstation and pick out the precise flow diverter size and length that would work in that situation. So instead of trial and error or having the wrong size and having problems, you actually did a computer simulation of your operation before you ever did it in the IR suite, which is way more advanced than what we're able to do here in the States. Of course, it's not yet FDA approved, so it's approved in Europe, But it's little things like that where you take technology, and with use of technology, creativity, and just sort of innovative thinking, you basically make the best of your situation. And that's what's the brilliance of Ukrainians. They always figure a way. Like in the United States, it was like, you come back to your hospital, it's like, it's an excuse. No, we can't do that today. It's not happening. No, we don't have that. We're filled. We're on red light. We can't take any more patients. It was never that case in Ukraine. It was always like, we'll find a way. We'll make a bed. Even if the bed is like in a hallway and you have intubated patients in a hallway, they always seem to find a way. They always seem to accept more, even when they have more on their shoulders. So I think that could be by itself very uplifting. So sort of a long answer to your question, but I think that's the thing. You look for the uplifting items and you try to pass it on. You try to learn from that and take it home. When you come back home to your trauma center or to your environment, you try to apply it. You try to not complain so much anymore. You try to say, I got to be really grateful for all the wonderful things I have back here. There's no air raid sirens going off at night.
Yeah.
I don't have to worry about any bombings in my house. It's like, and I have all kinds of resources to take care of patients, so I shouldn't complain.
All the vast majority of experiences that you have somehow influenced your approach in training the next generation of neurosurgeons.
Yeah. It's funny. So the next generation of neurosurgeons is already here. I'm 30 plus years into neurosurgery, so I'm on the way out. And so the next generation, I try to basically inspire them to do better than what I've done or what I'm doing. And I try to tell them, look to be better today than you were yesterday and better tomorrow than you are today, by seeing where we can make improvements, to take ownership in the patients. It's not just an attendee's patient. It's a patient that you're coming in contact with, that you're involved in the procedure. Have ownership over how that patient's care is managed. Be an advocate for that patient to make sure the best is being done. And then, the devil's in the details. Stay on top of all the details. Whether it's technical details in the operating room, the details in the ICU, details in the endovascular suite, historical details. Find out what was the patient's occupation before, what were their hobbies before, know them as a person, so you can understand what level of activity they want to get back to. And that helps you understand that. Understand the family's connection to that patient. What is their family support network like? Because ultimately that's where the patient goes back to. So understand more than just the MRI scan, the CT scan, the angiogram. Understand the human being behind all that to be better. And learn from your complications. Accept your complications when they happen. Learn from them. Be honest about them. And try to figure ways so that other people don't do the same thing that you did. And it takes a lot of humility to do that, because we have complications. We have things that don't go right. We have to figure out, what could I do to make that go better? What did I do why that didn't go the way I wanted to? And how do I prevent that next time?
And finally, war by its nature forces us to confront our own mortality. So how has operating in the war zone shaped your own meaning of life?
Boy, that's a pretty hefty question, right? I think the idea is that when you see so many young people whose lives are in danger or who are losing their life, and I'll get into my 60s this year, you realize how lucky you've been, but how short life is in the big scheme of things. That whatever you do, you need to pass on to the next generation, because we're not here forever. People remember you for maybe a generation, but by 3 generations, nobody knows who you even were.
Yeah.
And so the important thing is not who you are, but to take the lessons and the skills that you have and pass it on to the next generation. And so we do that like on a daily basis when we work with residents and fellows and others, younger attendees, and we say, why don't you try this? Why don't you do this? This is how I do this, but you might want to try something different, so that you can stay vibrant, stay active with that sort of educational process, realizing that, your days are numbered. And, war brings that pretty much right to heart. And spend your days doing something that really makes a difference for others. That's the big difference, is that you realize you see these people who are sacrificing their lives for humanity, for democracy, for civilization. I mean, they're really laying it on the line. And in your own little way, in your own little circle of life, figure a way that you can do a service for others and be someone who is a giver and opposed to a taker of life, in terms of your energies. And it's sometimes just very simple things, sometimes it's just saying a thank you to the people who don't get the recognition that they deserve, the people who are not necessarily at the highest level, who are sometimes at the lowest level, who are doing their job day in and day out, just thanking them and asking them what they notice, because they'll notice some things that you may never have noticed. People in the supply chain, people in the cafeteria, people in housekeeping, people in the lab, people who don't necessarily have exchanges with, just sort of connecting with these people as well, because, you can't do your job without everyone else doing their job as well.
Mm-hmm.
And, you sort of leave, but the mission continues. And that was always sort of a philosophy in the military, is that if you as the commander are taken out, well, the team doesn't stop. The mission doesn't stop. Someone else needs to be able to take over and keep going. And so you want that sort of to go on in life, where you made this positive little impact and it had a cascading effect, and maybe you inspired other people to be their better selves. Maybe you were that little Jiminy Cricket voice for them and you gave an example. And some of it was, leadership of just showing up. You just show up, whether it's a good time of night or a good time of day, on a weekend or a holiday, you show up and you're at the patient's bedside and you're doing an assessment. And then you're in the operating room, and then you're in the ICU, and then you sit down with the family and talk to them when things don't go wrong, or when things go wrong, rather.
Mm-hmm.
And you spend that time so you can lead by example. So
this was an amazing interview. Thank you so much. You're an inspiration.
Thank you. No, great questions. Fantastic. Yeah, no, I think it's great for folks to sort of stay aware of what's going on in the world, and to stay connected, and to realize that, what we do in medicine is only a small part of, what's involved in the big picture of humanity. But it's a very important picture because it's at the crossroads usually of a crisis. And there's a lot of things that we can do better. And a lot of things we can learn from the folks overseas in Ukraine and elsewhere, that I think, it's reciprocal learning. We're not just going there to teach. We're actually going there to become better and to learn how to take what they've done over there and bring it back to the States and elsewhere and say, let's try it this way. Let's make improvements. And that takes a lot of humility and a lot of awareness and a lot of insight. And that's probably the most important thing to sort of show up with, is basically be receptive to learning new things, that you don't have all the answers. So
yeah, that's true. To be curious, I guess.
Exactly. Forever curious.